ऑन करते हैं तो I can read it.
Hello, Abhati.
Hello, Pragya.
I'm just returning from Moria after a meeting.
Great.
Okay, I'm also just back from work.
So Priya, let's start.
Yes. So Chitakla, start sharing. Make it full screen. Yeah. So a very good evening and warm greetings to all of you present here in this webinar today. Namaskar, pranam and gratitude to all our esteemed chief guests of today, Dr. Gangadhar Sahu sir, President ISOPARB, Dr. Manju Geeta Mishra Madam, the backbone of ISOPARB, also the past president of ISOPARB, Dr. Usha Sharma Madam, immediate past president ISOPARB, who's the special guest, Dr. Pragya Mishra Chaudhary, the general secretary of ISOPARB, Dr. Hiralal Kunar sir, Arup Manji sir, who is the guest of honor of today, both of them. So I welcome all the dignitaries, and to this webinar is actually the launch session of the new committee of ISOPARB, the Fertility Enhancement Committee, headed by Dr. Lakshmi Srikhande Madam as the chairperson, and who is also the executive member of ISOPARB. Seed to Bloom series, the very first episode today is going to start. And with these words, I will first of all give my all gratitudes to all the participants, Dr. Abha Rani Sinha, everyone who has joined today. So, and with these words, I hand over the platform to Dr. Lakshmi Srikhande Madam. We start with Ganesh Vandana first. Let us start with the
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Thank you so much. Just to formally introduce Madam. Madam, she is Chairperson ICOG, Indian College of OBGY. She is National Corresponding Editor of JOGI, National Corresponding Secretary, Association of Medical Women, India. Founder, Patron and President, ISOPARB, Vidarbha Chapter from 2019 to 2021. Chairperson, IMS Education Committee. President, Association of Medical Women, Nagpur. The Nagpur Ratan Award she's been recipient of and by the hands of Union Minister Shri Nitin Ji Gadkari. Received Bharat Excellence Award for Women's Health. Received Mehru Dara Hansotia Best Committee Award for her work as Chairperson HIV/AIDS Committee FOXY. Received appreciation letter from Maharashtra government for her work in the field of Save the Girl Child. Senior Vice President FOXY 2012. President Menopause Society at Nagpur. In the year 2016-18, President Nagpur OBGY Society 2005-6. She had delivered 11 narrations and more than 450 guest lectures. She has many publications, 30 national and 11 international publications, and she has been sensitized 2 lakh boys and girls on adolescent health issues. So, Madam, she is heading this as a chairperson of this very new committee, Fertility Enhancement Committee of ISOPARB. So, this is the very important day. And this is the launch session with 2 brilliant speakers. She has invited Dr. Gaurav from UK and Dr. Parikshit Tankser. So over to you, Dr. Lakshmi Madam.
Thank you. Thank you so much, Supriya. And very good evening to one and all. First and foremost, I place on record my sincere gratitude to ISOPARB President, Dr. Gangadhar Sahu sir, ISOPARB Secretary, Dr. Pragya, and the whole team of ISOPARB for placing faith in me and starting this new committee, that is Fertility Enhancement Committee. And today is the launch webinar of this committee. What exactly I am planning under this committee is that monthly I am planning to have a topic covered where I wish to have one national and one international speaker, so that we get both national and international perspective to that given topic. So that is the whole idea. And why Seed to Bloom series? Because here we are planning to cover A to Z of infertility from basics to advanced. And I'm so happy that this committee will be catering to the reproductive biology aspect of the ISOPARB, which is also a very, very important aspect. So I take this opportunity to welcome our today's chief guest, Dr. Manju Geeta Mishra Madam, Dr. Gangadhar Sahu Sir, guests of honor, Dr. Pragya Mishra, Dr. Arup Kumar Maji Sir, and our special guest, Dr. Usha Sharma Madam. And I take this opportunity to welcome both the speakers, Dr. Gaurav Misra and Dr. Parikshit Tang, along with the chairpersons, Dr. Neeralal Kunar, Dr. Archana Kumari, Dr. Parul Kotadawala, and Dr. Abharani Sinha. And I also place on record my sincere thanks to Dr. Supriya Jaiswal, who is co-convener for this entire Seed to Bloom series. And I invite everyone to join me for the lamp lighting. All the chief guests, guest of honor, special guests, speakers, chairpersons, please join me for this lamp lighting. Yeah, Chitrakala, please start. Great. So once again, I invite everyone who is present here to join me for the launch of this web series, that is Seed to Bloom. Thank you. Thank you all. So now, after taking blessings from God, it is the time to take blessings from our seniors from the ISOPARB. So first, I would like to have blessings from Dr. Manju Geeta Mishra, who is a motherly figure and she is a mentor to we all ISOPARBians. To introduce formally to Madam, Madam is a past president IMA Bihar State, Madam is past president of National ISOPARB, and you all can see that she was chairperson Medical Education Committee of FOXY, and the list is endless. She has delivered so many orations, guest lectures, and she has attended national, international conferences with many, many publications and awards to her credit. So Manju Geeta Mishra Madam, thank you for joining us. Please bless us with your blessings.
Good evening to all of you. Respected President, ISOPARB, Dr. Gangadhar Sahu, Secretary ISOPARB, Dr. Pragya Mishra, President-elect Dr. Arup Kumar Maji, and the past President Dr. Usha Sharma. First of all, I must thank Dr. Lakshmi Sri Khande for taking initiative and having a keen interest in the ISOPARB activities. And I must congratulate her for this launching, making new committee of ISOPARB, that is Fertility Enhancing Committee of ISOPARB. This is the new committee. So I must thank Dr. Gangadhar Sahu, President, and Dr. Pragya Mishra, Secretary, because during his tenure, many new societies have been launched in ISOPARB, so that more and more activities will be performed under these committees. So on 14th March, Contraception and Reproductive Health Committee was launched by Dr. Shobha Gudi. And now today, Dr. Lakshmi Sri Khande has taken initiative and she going to launch this Fertility Enhancement Committee of ISOPARB. And rightly she said that this is most important part of ISOPARB, the ISOPARB, Indian Society of Perinatology and Reproductive Biology. So it will cover the reproductive biology part. So I must thank Dr. Lakshmi Sikhande, and I have worked with, in many conferences, I have worked with Dr. Lakshmi Sikhande. She's very hard-working Foxian, and any work she takes, she does it very elaborately, and she takes very keen interest in organizing any activities, whether it is Foxy activities or ISOPARB. So thank you, Dr. Lakshmi, for taking a keen interest in ISOPARB. So I must thank you and congratulate you for coming and taking this initiative. And I thank all the speakers, especially the speaker from UK, Dr. Gaurav Mishra, going to give light on the fertility preservation surgery. And Dr. Hira Lal Kanar and Dr. Archana Kumari, they both are chairpersons of this topic. And second,
thank you so much.
covered by Parikshit Khan.
Thank you so much. Thank you.
So once again, I thank Dr. Lakshmi Sikhande, and I congratulate the President and Secretary of ISOPARB for having so many activities during their tenure. So thank you very much. Thank you very much.
Thank you. Thank you so much, madam, for your appreciation and your blessings. And now it's time to have blessings from our visionary, dynamic National President ISOPARB, Dr. Gangadhar Sahu sir. Sir is retired professor and HOD. He was Dean IMS and some hospital Bhubaneswar. Pro Vice Chancellor. Currently he is our National President of ISOPARB. And as in his own words, sir is a disciplined learner, passionate teacher, a versatile orator, which we all have heard him, a preacher of human values, writer, philosopher, team leader, gifted healer, and a very, very extraordinary human being, I must say. So, sir, we are expecting and waiting for your blessings for this launch program of our committee. Sahu, sir.
Namaskar. Thank you, Lakshmi Madam. Blessings from Lord Jagannath and greetings from ISOPARB and Odisha. So many appreciations to Lakshmi Madam by Manju Gita Mishra Madam, the legend and doyen of ISOPARB and obstetrics. I'm jealous of you, Lakshmi Madam. So to start with, this is the launching day of a new chapter, that is Fertility Enhancement Committee. And the title of this show, that is very, very interesting, Seed to Bloom. It is both a philosophical and a scientific title. So congratulations for selecting such the title to start with. So my due respect to Manju Gita Mishra Madam, who is the motherly figure. I always seek that her hand should be on our head for the ISOPARB to grow. Professor Arup Kumar Majhi, the president-elect, which I pay respect as my younger brother. Dr. Pragya Mishra, again a dynamic Secretary General. My respected elder sister, Dr. Usha Sharma, the immediate past president of ISOPARB, are the special guests, all the esteemed chairpersons and the speakers. Aptly, these topics are being chosen: fertility enhancement surgery, that will be delivered by none other than an international speaker, Dr. Gaurav, as the beautiful, idea that has come to the mind of Lakshmi Madam, that one international speaker and another national speaker. So a combination of both exchange of ideas, exchange of values, exchange of knowledge that will definitely enrich the ISOPOR as a whole. Therefore, I owe a lot, Lucky Madam, for the growth of ISOPOR. I cannot forget another convener, that is Supriya Jaiswal, the most dynamic lady of the ISOPOR, who works silently behind the screen, but the overall outcome is simply marvelous. So being a coordinator, I always feel that she is a lifeline of ISOPOR. May God bless her. So may all the participants and speakers, I pray Lord Jagannath to bless you everybody and wish this ISOPOR to go sky high. Long live ISOPOR, long live ISOPOR, long live ISOPOR. Thank you, Lucky Madam, for your noble idea. Thank you very much.
Thank you so much, Sahu sir, for your blessings. And friends, we have launched this program in Sir's tenure, but this series will be continuing during Dr. Maji's tenure, who is our incoming president of National ISOPARB. And to introduce our today's guest of honor, Dr. Arup Kumar Maji, you all can see he is Professor Shantiniketan Medical College at West Bengal. He will be taking over as national president of ISOPARB in the last week of April. And he is author, bedside clinics in obstetrics, bedside clinics in gynecology. So I think, sir, your core interest is in the basics and the bedside of obstetrics and gynecology. Sir was former professor and head of RG Kar Medical College, Kolkata. He was also president of Bengal OBGY Society, and currently we all have witnessed grand AICOG which was held at Kolkata, and sir was scientific committee co-chairperson, and sir, we really enjoyed the academic feast and other the hospitality and everything was simply superb. Sir has also got many awards to his credits and a great number of publications, and he was also past national corresponding editor of our Jogi journal. So sir, now the pearls of wisdom from your side.
Thank you, Dr. Lakshmi. I do not tell Lakshmi Sekandre, I tell Lakshmi Saraswati Sekandre. I should tell, and everybody should tell. We have seen her academic capability. So thank you for your nice introduction. Good afternoon, everybody. Dr. Gangadhar Sahu, our president, ISOPARB, and Dr. Dr. Manju Gita Mishra, the pillar of our ISOPARB, and who always bless me, and our chief guest, and Dr. Usha Sharma, just immediate past president, and a special appeared as a special guest in this session, and Dr. Pragya Mishra Chaudhary, who is actually the very dynamic, and will have to work together for the next year. He has already shown her capability in various areas. And now it is a great honor and privilege for me to be to present in the lunch session as guest of honor. I must again thank Dr. Lakshmi, who is a very renowned personality who has agreed to chair an important session of the Fertility Enhancement Committee, important committee. And she is launching, as Dr. Gangadhar Sahu is a beautiful topic, and particularly the name she has selected, the Seed to Bloom series. That is the first series is actually the launching, and the rest will be following. Probably it will be on every month during my tenure. And we also thanks Dr. Supriya Jaiswal, who is another convener of this series that will be held. And as all of you know, the ISOPARB is now very spreading rapidly for the last few years by our previous presidents, Dr. Usha Sharma, and the present president, Dr. Gangadhar Sahu, and almost the more than 34 chapters, and wish that many more chapters will come. We will want to penetrate in the interior of the of India, India, the country. And most important is that the ISOPAR mainly the deals with the parentology, but Lakshmi has clearly said, and also Gongata also said, it is the reproductive biology. It consists of one part is reproductive biology. And without reproductive biology, where there is the infertility and about the 1/6 of the couple cannot be without the periodontology cannot be improved. So that is the important aspect, and following the contraceptive committee by opened by the committee by the Goody, Dr. Goody, Shobha Goody. I must thank Dr. Lokhi Secondary. The another aspect of the reproductive biology, that is the fertility enhancement committee, to lead the fertility enhancement committee. And there are very renowned speaker today. All of you know Dr. Gaurav Mishra. He will speak on the fertility preservation surgery. And another is the Dr. Parikshit Tang will speak on the male body. Two important aspects of the infertility. And there are very renowned chairpersons here also, Dr. Kunar, Dr. Archana Kumari, Dr. Parul Kotadawala, and Dr. Avarani Sinha. I hope that today's this committee will enlighten our ISOPAR and will spread throughout the country. So thank you. Best wishes for the committee, Dr. Lakshmi. I am hoping we'll work together, and my thanks to all the committee members, and also faculty and delegates. Thank you all.
Thank you. Thank you so much, sir, for your blessings. And now it's time to hear our sincere, hard-working Secretary General of ISOPARB, that is Dr. Pragya Mishra. Friends, you all can see she is consultant infertility specialist, and she is currently Secretary General of ISOPARB. She was also chairperson of Genetic and Fetal Medicine Committee of FOXY. She is founder secretary of Bihar chapter of ISAR. She was vice president of Patna OBGY Society. She is examiner for MRCOG examinations, and she has been awarded with Asia GCC Award for Excellence and Leadership in IVF, Gynecology and Obstetrics. Friends, her list of awards is very, very long. To cut short, you all can read her list of awards, and she's a great organizer. She was organizing secretary of FOXY ISPAT conference way back in 2018. She was also organizing secretary for 24th BoxCon in 2014, and she was scientific chairperson for ISOPARB annual conference in 2016, which was held at Patna. So friend, she is a great academician, orator par excellence, and now we are waiting to hear you, Pragya, for your pearls of wisdom on this occasion.
A very good evening to all of you. At the outset, I would like to thank Dr. Lakshmi Srikhande for such a kind and generous introduction. I don't know whether I deserve all that, but so I would initially, first of all, congratulate you for the launch of your Fertility Enhancement Committee of ISOPARB. And chief guest, Dr. Manju Gita Mishra and Dr. Gangadhar Sahu, and guest of honor, Dr. Arup Majhi, Dr. Usha Sharma, our incoming, Arup Majhi is the incoming president, then Dr. Hira Lal Kunar, Dr. Abharani Sinha, and all the guest speakers. Forgive me if I've forgotten, and Supriya. So it's a real delight, it's like going back to 2020, 21 when we were doing all these programs on Zoom. Let me tell you that, ISOPARB has about 5 committees at present. And it's something, somehow our whole idea was not to increase the number of committees. We just want, less number of committees, but more of dedicated work. So, and since it is the Indian Society of Perinatology and Reproductive Biology, Now, initially, our first committee which was formed was the quiz committee, which is the oldest committee of ISOPARB. Then recently, last year, we passed in the executive committee meeting to start contraception and family planning committee and this fertility enhancement committee of ISOPARB, newborn committee, now which is yet to be, so we are still waiting for the launch of the first webinar of the newborn and for the rural committee of ISOPARB. So you can see, how meticulously we have chosen just these 5 committees, and we wanted to focus work on these committees so that, we benefit, the ISOPARB reaches to the doorstep of all the peripheral places of India. So that's the whole concept about having just these 5 few committees. And we were very sure, actually, we thought a lot, how to name this committee. Then Dr. Lakshmi Srikhande and myself, we finally decided that fertility enhancement seems to be the best terminology for this committee. So, and we also knew that Dr. Lakshmi Srikhande is going to take ISOPARB to greater heights through the work of her committee. And that's the reason we all unanimously nominated her as the chairperson of this committee. So I'm sure that, we are going to get a lot of, not only we are going to be wiser as far as academics is concerned, but through these academics, we are going to spread our knowledge, to the peripheral places of the country, because as you know, ISOPARB now has more than 3,000 members and almost 34, 35 city chapters. And most of the city chapters are concentrated not in the cities, but in the peripheral areas of most of the states. And our president, Dr. Gangadhar Sahu, has also in the last 1 year has tried his level best, to reach ISOPARB to the doorstep by involving people from these peripheral areas of the country to start chapters. So we salute to him for that. And and of course, congratulations for having chosen this terminology, Seed to Bloom, so apt for Fertility Enhancement Committee, and and the speakers that you have chosen, and your concept of having one national and international speaker. So we are all overwhelmed at the launch of your this very new committee and your first webinar. So, and thank you for the opportunity, and thank you for making me a guest of honor. So, so I think we can start now with the scientific session. And well, I think I've already named Supriya, who you have chosen as the co-convener of your committee series. So, thank you so much, and congratulations and best wishes. I think most important is best wishes, for this committee.
Thank you so much, Pragya, for all the support, help, and guidance for starting these web series. And now, friends, it's time to hear from the soft-spoken guiding force, who is immediate past president of National ISOPARB, and she is Dr. Usha Sharma. She is consultant OBGYN at Patna K Memorial Hospital, honorary consultant at Red Cross Polyclinic, Patna. She was chairperson of Safe Motherhood Committee, POGS. She has delivered many keynote addresses, orations, scientific deliberations, contributed n number of chapters in Foxy publications, and she is a great, great academician. Madam, we are eagerly waiting to hear pearls of wisdom from you.
Good evening, and can you hear me?
Yes, madam.
First of all, thank you, Lakshmi, for inviting me as a special guest. Thanks once again. Now, it gives me immense pleasure to be a special guest for launch of Fertility Enhancement Committee, which is a very good and a new name of ISOPARB by none other than academic and dynamic Dr. Lakshmi Srikhande, who has many laurels to her credit. She has taken upon herself to convene the program as well, so we can look at your energy level. Okay, ISOPARB has great expectations from you, and I am sure that you will take this committee to a greater height. The dignitaries, chief guest, respected Dr. Manju Geeta Mishra, President Dr. Gangadhar Sahu, the two guests of honors, President-elect Dr. Arup Kumar Majhi, and Secretary General, Dr. Pragya Mishra Chaudhary, along with the chairpersons, Dr. Hiralal Kunar, Dr. Archana Kumari, Dr. Parul Kotawala, Abharani Sinha, will enjoy the talk on fertility preserving surgery by Dr. Gaurav Mishra from Midland, UK. And the second talk, Dr. Parikshit Tank, will be on male infertility. Dr. Supriya Jaiswal, another dynamic member of ISOPARB, is an executive member right now and is the co-convener for this launch. I congratulate Dr. Lakshmi Srikhande and wish her committee a grand success in future. Happy learning to all webinar attendees. Long live ISOPARB.
Thank you. Thank you so much, madam, for your blessings. And I place on record my sincere gratitude to our today's chief guest, Dr. Manju Gita Mishra, madam, Dr. Gangadhar Sahu, sir, our guest of honor, Dr. Arup Kumar Maji, sir, Pragya Mishra, and our special guest, Dr. Usha Sharma. So now we would like to start with our scientific session. And friends, here I would like to hand over to Dr. Supriya Jaiswal, who is a very good friend of mine. And without her help, this series would not have taken its shape what you are seeing it today. Friends, to introduce Supriya, you all know she's a versatile, dynamic person, full of energy and ideas, and lot of creativity on her part. Currently, she is Vice President of Patna OBGY Society. She is Chairperson of Adolescent Health Committee of FOXY, Joint Secretary of Sauci, Bihar and Jharkhand Chapter. She is Chief Consultant, SM Hospital, Patna, Executive Member of Central ISOPARB, and she's a great organizer, as I already said, full of energy. She has received various awards. She has held many positions in various organizations, and she is having special interest in high-risk pregnancy and preventive oncology. So now I hand over the proceedings to the co-convener of this Seed to Bloom series, Dr. Supriya Jaiswal.
Thank you, madam. Thank you for the wonderful introduction. Thank you for so much. So thank you once more for making me the co-convener, and I'm privileged today to start this scientific session. So gaining knowledge is the first step to wisdom, and sharing it is the first step to humanity. If you have knowledge, let others light their candles to it. So with these words, I start the scientific, and the first session we have the speaker, Dr. Gaurav Mishra. To chair the session, we have Dr. Hiralal Kunar, sir. Can I have the CV? Dr. Hiralal Kunar, sir, he is Professor and Head Department of OBGY at Kolkata. The Scientific Committee AICOG 2023 Kolkata. He was the Chairman, Indian College of Obstetrician and Gynecologist. Then Vice President FOXY 2008, President Bengal OBGY Society in 2008 and 9. National Corresponding Editor, Journal OBGY Society, that is Jogi, Editor-in-Chief of Journal ISOPARB, FOXY representative of Asia Oceania Federation of Obstetric and Gynecology, then member of Oncology Committee of AOFOG. So he's been the author of so many textbooks of obstetric gynecology and many more. So, sir, with these words, I welcome you to chair the session. The next chairperson is none other than Secretary ISOPARB Ranchi Chapter, Dr. Archana Kumari. She is the Founder Secretary IFS Jharkhand Chapter, East Zone Coordinator Quiz Committee FOXY, FOXY representative of ROGS, Convener Clinical Research Committee FOXY, and Vice President Ranchi OBGY Society, being Secretary Ranchi OBGY Society in 2009. She has been the organizing secretary of FOXY, very successful FOXY East Zonal Conference with UVA 2022 at Ranchi recently. She had been the organizing secretary of 8th annual conference of ROGS, then organizing secretary of many other conferences. So she has got a huge teaching experience of 18 years. And with these words, she's been awarded with many MS Signature Award and several others, Dhira Award, etc. And so with these words, Dr. Archana Kumari, I just welcome you to the chair the session. And I also request Dr. Can I have the next CV, please? So kindly introduce Dr. Gaurav Mishra, sir.
Yes, thank you, Supriya, for a nice introduction. At the outset, I would like to express my gratitude to my mentor, Dr. Minjugupta Mishra, Gangadhar Sahu sir, President ISOPARB, Pragya Mishra, Dr. Pragya Mishra, Secretary General ISOPARB, and of course, the very dynamic and versatile chairperson of newly launched this Fertility Enhancement Committee of ISOPARB, Lakshmi Srikhande Madam, for giving me this opportunity. It is indeed a privilege to introduce such a renowned speaker from UK, Dr. Gaurav Mishra. Well, sir is a consultant gynecologist in University Hospital of North Midlands Stroke on Tent. He's the honorary senior lecturer, Keele University, United Kingdom. Minimal access lead at University Hospital of North Midland, and he's the divisional research lead at UHNM. He is actually leading the gynecology and early pregnancy unit and ultrasound at Royal Stroke University Hospital, and he is also the endometriosis center lead at UHNM. And he has been awarded a fellowship FRCOG from Royal College of Obstetricians and Gynecologists in London. So the floor is yours. We are eager to hear from you.
Thank you so much, esteemed all my colleagues, my seniors, and a big, very good thank you for Dr. Lakshmi Srikhande for inviting me, and it's just a pleasure to be among you all. It's just that I'm in between theaters, so I hope it's not going to be disruptive. So I'll just share my screen. So let me just start. Can you all see my screen?
Yes, fantastic.
Okay.
Great.
The topic when Dr. Srikhande asked me to talk about, we're a big endometriosis center because the way deep endometriosis is being treated in the UK is slightly different. And I think we're doing quite well in terms of managing endometriosis patients. So I'll just limit my talk to deep endometriosis because in half an hour, you can't talk all about endometriosis and fertility preserving. So just to give you a background that what is the UK perspective in dealing with fertility preserving surgery in deep endometriosis patients in the UK. So see, the prevalence of endometriosis in the UK, and this is UK data, is about 3 to 10%. So what does that mean for us, as clinicians? So see, the burden range can be, the disease burden can be between 0.3 to 1 million cases. Now, UK is a small country, it's only a tiny fraction. And the prevalence of severe endometriosis can be anything between 5 to 30%. So that means there's about 15,000 to 300,000 cases within a lifespan of 30 years of a fertility life. Now, conservative estimate, and these are just estimates, it's probably just tip of the iceberg, that about 5,000 women in severe disease in the UK requiring surgical treatment. This is for surgical treatment, 5,000. And probably 3,000 in UK. And that's where the concept of endometriosis centers came up in the UK, led by the British Society of Gynae Endoscopy. Because I don't think we were offering these group of women the right choice of surgical treatment because in a multidisciplinary setting. So what is the BSG accredited center? So there's 67 centers. You have to be part of the BSGE. The first year is provisional, and then the last, from next year, you get a full license for the BSG center. What do you need for that? You obviously need the multidisciplinary team with minimal access trained gynecologists, colorectal urologists, and specialist nurse pain management. So you have to have all of this. Minimum cases, depending per gynecologist, should be at least 12 per year. In our unit, we do about 70 per year because we are a tertiary referral center. And obviously, the main thing is data collection with pain score, quality of life. It has to be preoperative 6 months, 12 months, and 24 months, and surgical details and fertility wishes. So these all data collection have to be done. So what happens when a patient gets referred to us with suspected deep endometriosis? There's two scenarios. One is they've either been diagnosed in elsewhere, or somebody is suspected, done an MRI on an ultrasound scan suggestive of deep infiltrating endometriosis, but they wish fertility preserving treatment. So they're seen by our endometriosis team, mainly by our endometriosis nurse first, assessed with the symptoms, as I've told you, for data collection. And then they're organized either an ultrasound or an MRI. Now that's also depending on which centers you are. In our center, we do more MRI because our radiologists are more trained with MRI rather than ultrasound for deep endometriosis. And there's a lot of centers doing ultrasound, which is equally good. So once we've done that, we tend to see them jointly in our endometriosis clinic. So we've got a dedicated clinic where there's a gynecologist, there's a colorectal surgeon, there's a urologist, and the pain team nurse. So we do twice a month. And these patients are seen there and offered various modes of treatment. And these are a group of patients who wanting to have surgery because of their symptoms and fertility or both. So once they've been decided that, look, this is what their MRI is, we do the team meeting, we counsel the patient that this is what the surgical options would be, then they make an informed choice. And then they have joint surgery between us. Now, not necessarily always they'll be needed with a colorectal or thing, but those patients who are booked on the joint list, we always make sure that there's somebody available just in case if we need any help with the bowel or the ureters or bladder. So once they've had surgery, then they come back and see our practice nurse in 6 weeks to see if they have had any problems with recovery. And then they're seen in 6 months, 1 year, and 24 months. In the meantime, obviously, if they want to pursue, either they want to get pregnant themselves or go for IVF, we then triage them to that unit. So this is the whole pathway which happens in our place. Now, what's the data? See, I mean, it's very difficult to get randomized controlled trials, but the biggest data we had in terms of fertility preserving also, or with hysterectomy, is from the BMJ Open, which was published about 6-7 years ago from all the endometriosis centers. And if you see, although it's a cohort study, it's the biggest study data so far among does quality of life change with performing surgeries? Because see, we're doing these surgeries, which are quite extensive, breaking our backs, probably lasting 3-4 hours. Does it make a difference? That's what people want to know. And if you look at that, and that was the thing which was published in the BMJ. So what's the results? Obviously, it was a multi-center observational study. There were over 5,000 patients, and that data is still going on. So by now, we would have had probably 8,000-9,000 patients on there. And there was significant improvement in quality of life. See, the question is, fertility is obviously related to quality of life. You can't expect somebody to try for either natural conception or go for if they're in pain every month all the time. So these are the group of women who had significant improvement in their quality of life because they were offered surgery. There was a significant reduction in cyclical and non-cyclical pain, dyspareunia, dysphagia, and low back pain. But the overall rate of complications was about 6.8%. And you would expect that because these are surgeries which excuse me, which you're doing with the bowel, bladder, maybe sometimes you need to go into the sacral plexus, yeah? Our data suggests, our complication rates are pretty much the same, but we do keep a very close eye. So we just got a bit of a sore throat. Now, see, every year we are audited in terms of our things. So we have to submit all our data, and that's how we get accredited every year for the endometriosis center. Now, what's ESHRE say, the guidelines about endometriosis and surgery? See, we know that in superficial endometriosis, it is helpful, but in deep endometriosis, we don't know. But there is some evidence to suggest that in patients, if you do offer them surgery, it can make a difference. So see, offering surgery for deep endometriosis is not really to enhance their fertility because we don't know the evidence. You're treating their symptoms, and obviously they have a wish to preserve their fertility, to either go for IVF or try for natural conception. And that is how we consult the patient. So if, say, a patient who is pretty much asymptomatic, but comes in with endometriosis involving the bladder, bowel, or a bit of the ovary, and they ask for surgery that I want to get my fertility enhanced, that's not something we should be offering. Now, these are just some examples of, some good outcomes we've had. So this was a patient who's in fact one of our orthopedic colleague trainees. She came to us being referred from another hospital. She was 31 years old, primary subfertility, diagnosed with pelvic pain, severe pain, had a laparoscopy in a neighboring hospital. They found a obliterated pouch of Douglas and was sent to us. So we counseled her and she opted for surgery. So we did say that, look, you've got an option to even go for IVF or surgery, and she opted for surgery because of the symptoms she was having. She just couldn't continue like that. So this is like we operate in a multidisciplinary setting with most of the surgeries we do, and there's always a colorectal or a urology around if we need them. Now, we tend to use quite a lot of diluted vasopressin for these surgeries because you'll see, obviously, the anatomy is quite deranged. And you will see the vascularity is a lot higher. So just using little things like, a bit of diluted vasopressin in 80 to 100 mils and injecting them into the broad ligaments or the pelvic side walls helps. Now, the main thing is we're trying to get a near normal anatomy. It's never going to be a complete normal anatomy, but the main thing is trying to separate. See, the kissing ovaries are very common. I'm sure all of us have come across it. The main thing is trying to separate the ovaries from the pelvic side wall. And then we deal with the disease. And the disease with deep disease is we know that excision's better, because there's no point just diatherming the deep disease, because I don't think that's very helpful in terms of things. So the first thing we try and do is try and get the ovaries, if they're stuck down, peel it off the pelvic side walls, and then do the ureterolysis, because I think that's a really important thing to do if you're dealing with central compartment disease. So opening the pelvic side wall. Now, a lot of these cases now we've converted to robotic surgery, not that because I think the results are better, because we don't know that. It's just for us, and we, in conjunction with the urologist and the colorectals, we feel much better physically after performing these surgeries. So we tend to do these surgeries more robotic. The only thing is getting access to the robot can be a bit difficult. So that's why some of them we still have to do. But I think it's a fantastic platform. It is expensive, but, obviously, I think in the next few years, you'll see there's a big boom of robotic surgery all over the world because the costs are coming down. We've noticed that in the UK because of thing. Now, if you see that, so the way we approach the pelvic side wall disease is obviously the ureter, the IP ureter, and the uterosacral. So it looks like a railroad, you see, and this is where we approach all central disease. So work from the sideways to the middle, excise any sort of deep disease you think would be relevant. Nerve sparing surgery is really important if you're going a bit deeper than that. See, it's very common to the uterosacral to get stuck to the rectum, and that's how the nodules start growing into the rectum. And then now the question is, what do you do with the endometriomas? Now, see, there's lots of debate and studies that do we strip them? Do we not strip them? Do we laser them, or do we use helium, or what do we use? Now, see, the problem is, when there's so many theories, there's not an absolute right outcome. See, if we go in surgically, we tend to strip the ovaries. We do an pre-operative anti-Mullerian hormone just to get an idea, but we don't do any post-operative because it's not helped. We tend to think, because we feel that from our series, the rate of recurrence of endometriomas is less if we tend to, strip the thing. Now, some people would drain it, and if they use laser, we don't use lasers in our hospital, so we don't. Diatherming the base, I personally, anecdotally, I don't think that works too well, or would that have an effect on the ovarian reserve? Possibly. But we tend to do that thing. And then we always obviously suture the ovary, because we don't leave the ovaries open. Again, anecdotal, whether there's going to be a lesion. And if she does go for egg collection on later, would that be a difficult thing? So this woman recovered really well. She was kept under a follow-up, and then she went for IVF because she was trying for over 2 years. And then she had a successful pregnancy and, had a cesarean because I think she opted for a cesarean. So that was one. This is a patient again who we did, she was 38-year-old. She was a para 1, but she had endometriosis and came to us for fertility preserving surgery because she wanted to try for thing. Now, in UK, you see, if you have one child, you are not eligible for NHS fertility treatment for IVF for things. So you have to self-fund. So she was very keen to have her endometriosis treated for her symptoms mainly, and then she would try naturally if she conceived. Yeah. So this is where I was just showing you a little bit of the robotic thing. Now I know is Dr. Lakshmi is very used to robot, but those who are not familiar, I think I would say that if you get a chance, just try getting on the platform to see. It's a completely different thing. It's a 3D vision. The image is second to none. And you're not dependent on your assistant to hold the camera to keep it stable. It's just different, and when you're operating on cases which is going to take longer, I think this will be the future in terms of surgeries. In our unit, the reason we're trying to move robotic, because our colorectal and urology colleagues, they've forgotten how to suture laparoscopy because they don't do any laparoscopic surgery. So if there's a bowel, say a disc resection, we suture, they're just there because of medical legal reasons. Similarly with bladder and all, we suture because they just do not suture laparoscopic. So they feel more confident with us in doing these cases laparoscopic, because if there's suturing or anything needed, then they could do that. But just the vision on, and obviously the technology is so good. I think in deep endometriosis, a lot of centers are moving towards performing these surgeries, robotic thing. You will see there's more data coming out. There's Professor Roman in Bordeaux in France, who was starting to publish a lot of data with deep endometriosis and on the robotic platform. And I think you will see a lot more data coming out in the future regarding, the robotic surgery. And it's just so stable. You're controlling the forearms. You're not dependent on anybody else. And I think post-operatively, anecdotal, but we feel that the pain scores are significantly less even compared to laparoscopic surgery. So that's where you are. So this patient, had surgery, had a very good outcome, and then she did go for, IVF because she had to self-fund, but she had a successful pregnancy and then had a delivery. So see, this is where, look at the enhancement of these photos compared to even laparoscopy. So when you're doing dissections, when you're doing the ureterolysis, and you've got the advantage of Firefly, so you can put ICG in, the intrazine in green to check. And I think this is going to be probably a game changer in managing these difficult cases. Okay, I'm just going to move on to the next one just for things. So this was a lady who was a 28-year-old, was again referred to us by, she had an acute admission into the hospital with pelvic pain, rectal bleeding, and she was becoming, with rising infective markers. So she had a CT scan done first, which suggested a rectal mass, and then she had an MRI. She had a colonoscopy, which suggested sort of a polyp-type mass in the rectum. She had a biopsy taken from that, which suggested endometriosis. So you can see how these patients can present. So she came to us. She had a complex mass in the left adnexa, which looked infective. The CRPs were rising. It was 120, I think. And she was obviously very keen on, because she didn't have any children. So we offered surgery because of the sepsis and the thing. And then you can see that this is we don't see this often, a completely infected endometrioma. So this is the cyst on the right, which is plastered to the uterus, and this has got infected. So this was a 28-year-old. And so we obviously trained the thing. We decided to do the oophorectomy on that side because the other ovary looked okay, just because she was septic. And then you can see how big. So I'm just going to forward that video because I know we're a bit thing of time. See, this is the ureter. We had stented her on this one. We stent about 10 to 12% of our patients. Previously, we used to do a lot more, but now we tend to ureterolyze. So this is just taking the left adnexa off. Now that's the right ovary there. And I'll show you in a bit the huge rectosigmoid nodule. This was a full thickness, about 6 centimeter nodule she had. So we had to do a segmental resection and anastomosis in her. So that's the big nodule there. And this was the one which is completely full thickness. So she was having bleeding and she presented with a complex marks of the rectum to the extent that she presented to the colorectals thinking that whether it's rectal cancer. So eventually, obviously, this is where, our colorectal colleagues get involved. They skin the rectal stump out completely. And then we use the echelon guns to staple and then do anastomosis. Now, this is not anterior resection. This is just segmental anastomosis. So we don't go up to the inferior mesenteric vessels. So that's where you see it's looking a lot cleaner there. And then I'll just show you the last bit where it's been stapled across that segment. And then it's the anastomosis will be done. So that's the lower segment there. And this has become so good with staplers, and that is where the colorectals, they don't suture unless they do pelvic floor work. They don't need to suture anything. See, so I think in laparoscopy world, we gynecologists will be doing majority of the minimal access suturing because neither urologists know thing because they'd all either staples or robot. So this patient had an end-to-end anastomosis. We didn't leave a drain in. She didn't need a defunctioning because it wasn't under tension. She recovered well. These patients, we tend to keep them in hospital for about 3 to 4 days. Not that movement of bowel, but as long as they're moving flaters, they're obviously markers and, the early warning news system, what we call here, is okay. We let them go home and then we obviously see them back. Now, this again, patient had a successful pregnancy 2 years later, and she came back to see us with the baby and it was a thing. So I think these are very difficult cases. Now, as I said, our aim for surgical, management of these patients are not just based on fertility. It's mainly based on symptoms because these patients, they suffer all their life, and obviously fertility is a significant part of that. Thank you. I'll just stop there because I know we're running out of time. I'll just stop sharing, if that's okay. I'm happy to take questions, and then I'll have to go back into theatre in a little while. Yeah. Thank you, ma'am. Thank you so much.
Thank you very much, sir. And Lakshmi, ma'am, will you?
Yeah, I know Gaurav is in between the OT and he was looking at the theatre. But thank you so much, Gaurav, for logging in and sharing.
My registrar is so happy that you guys have called me because I can stay away and he can do everything. So he's asked me to thank you guys.
Sir, Dr. Hiralal Konar will sum up your talk.
Mr. Mishra, thank you very much. Thank you very much. We have enjoyed this session also. Because my experience of dealing such cases of advanced endometriosis in the Center of Reproductive Medicine, Calcutta, Professor B.N. Chakraborty, we are facing this problem. And we are doing, obviously, your surgery is a bit higher quality in terms of entirely laparoscopic, all the gadgets, and that of the robotic part, and that of using the harmonic. That's enormous advantage dealing with such cases. Honestly speaking, I cannot forget one girl of 14 years, advanced endometriosis. We did repeated surgery, ultimately resection, and then colostomy. Ultimately, she ended her life. But coming back to our own subject, that is the fertility preservation these days, we are mainly looking for, that these days there is a trend in the changes of quality of life. We world over, there is more problem of the cancers, early onset of cancers, to the extent of reproductive age group to the extent of 5 to 9%. And then fertility preservations in terms of endometriosis has got the infertility problem number of ways. Apart from that of the anatomical distortion and that of the anovulation, ovarian pathology, oocyte quality is affected, corpus luteum function is affected, implantation is affected. All that this problem is there. But again, then fertility preservation, especially in those groups, because we are anticipating that progressive rise of cancer disease now, maybe that by next 2 decades it would be double. But death of cancer has been reduced with the effective treatment and early diagnosis. Now coming to that of the fertility preservation, the question comes that of the oocyte preservation. I have already faced in our center 3 such cases. One, that of case of borderline ovarian cancer, that we did surgery one side, contralateral preservation, and she obviously with counseling, taking the risk, Mr. Gaurav, problem is that we have got no data at the moment. We cannot tell honestly how much is the chance of having a healthy baby, how much is the chance of recurrence of cancer. So both the things have to be explained. We need to understand, we need to go for that. And successfully, that lady had her baby and we did the complete surgery later on. Another lady that she's waiting with me, her surgery has been done with that of the advanced ovarian cancer. Her ovarian tissue has been preserved on the other side. Now she is married, everything has been counseled. Now we are proceeding for that of the ovarian tissue cryopreservation and the surrogate, and then having a own genetic material, biological child that we are waiting now. Another of my experience is endometrial carcinoma. You see, that lady, she is working here in Mumbai. She came to us in the center that endometrial cancer, it is obviously early stage, no myometrial invasion. We did the initial surgery, hysteroscopy procedure, conservative management. Now we are proceeding for that of this successful ovulation induction and the conception. So fertility preservation in cases with different areas of endometriosis, oncology, like that of the oocyte preservation, embryo preservation, ovarian tissue preservation, everything is possible these days. So this is the another advanced progressive area of the biological science that Lakshmi has decided to go ahead with this knowledge spreading across the country, all the gynecologists. Thank you very much for highlighting this difficult topic with all the beautiful surgery, having the concept of conservation as much as possible. Thank you very much. Thanks to the organizers, ISOPARB, this society, I joined in 1989. It is growing leaps and bounds. It is becoming so popular. And the leadership, you see the dynamic leadership. We wish you to be involved also in our society.
Absolutely.
So great. It is a great pleasure. Thank you once again.
With permission of the chair, can I ask a question from Dr. Mishra?
Yes, please.
Of course.
Yes.
Make it short and sweet.
After such an,
Hi,
I know
ma'am.
you're getting late for theaters, but
No, it's okay.
so I mean, after such an extensive surgery, for endometriosis, and well, we are all trying to preserve fertility. So these patients, would you give them GnRH analogs, at least 3 shots, or?
Yeah, ma'am. So see, this is where there is no data, or I think if you look at the ESHRI guidelines, they come up, although the data isn't very strong, they try and say that if say you're doing surgery and these patients want to try and get pregnant in the near future. Now, near future is, I'd probably consider in the next 3 to 6 months, then the suggestion is usually do not put them on any hormonal treatment. If they want to leave it a bit longer, then it's worth, because what they're saying is short-term data, by putting them on hormonal treatment, you're probably just delaying the inevitable. So that is why the general consensus, we also tell patients, look, if you're planning to get pregnant or go for IVF or whatever in the next 3 to 6 months, then we don't tend to give them GnRH analog. No. Pre-treatment, again, it's for symptoms. It doesn't make surgery any easier, so we do not give them pre-treatment thing. A lot of the patients who are not planning for fertility straight away, they go on to some form of treatment, probably Dynagest or something, but not if they were planning anything.
Okay. But suppose if you did give, then would you be giving 3.75 at monthly, or because I worked in England for 5 years and there people were more fond of 11.25 one shot.
So see, in our
even before the patient left the hospital.
Yeah, absolutely. See, in NHS, the problem is it's so difficult to get patients back on follow-up every month. We tend to offer them the 3-month one with add-back HRT, because otherwise, our clinic surgery, and after the COVID is just, we just can't get them back in time. So 3 months, usually patient prefers as well. Obviously, we're now converting a lot of our GnRH analogs to Dynagest, because we've seen the side effect profiles better. And obviously, it is reversible straight away if they don't have side effects, or if they don't like it, or they want to change plans instead of the GnRH analog. And it's a cost saving to the NHS with the Dynagest and things. So we're preferring more of the Dynagest rather than the GnRH.
Thank you.
Thank you. So we are over with this session, and thank the speaker, the excellent speaker, Dr. Gaurav Mishra from UK, and the chairpersons, Dr. Hiralal Kunar and Dr. Archana Kumari. Thank you very much.
Thank you, Gaurav. Thank you so much.
I'll take a leave.
Yeah, thank you.
I'll take a leave. Thank you so much. Thank you.
Thank you, Gaurav.
Thank you.
So now we come to the second topic, the male infertility, session 2 of this program. So we have a wonderful speaker, Dr. Parikshit Tang sir. And then to chair the session, we have Dr. Parul Kotawala sir, who is an endoscopic surgeon and consultant gynecologist, Department of OBGY VS Hospital at Ellisburg, Ahmedabad. Then he's vice chairman, ICOG 2020, vice president ISOPARB. He was vice president in 2022, vice president FOXY 2006, president SOGOG 2009, president AOGS 2007-8. So he's been the managing committee member in SR and IAGE, India coordinator, NESA, India coordinator, IAS. So with these words, sir, I welcome you to chair this session. Thank you very much. And then Dr. Abharani Sinha, the second chairperson. Madam is Professor and HOD OBGY, SKMCH Muzaffarpur, ICOG Governing Council member at present 2021-22, President Patna OBGY Society in 2017-18. She had been the chairperson quiz committee of FOXY, a very vibrant tenure of hers, national corresponding editor of Jogi, UG and PG teaching experience of more than 26 years. To her credit, contributed chapters in FOXY publications. She'd been the joint organizing secretary of AISUG 2014, being the master trainer for FOXY EMOC, special interest in high-risk pregnancy and vaginal surgery. She had been awarded with MS Signature Award in 2021. With these words, I welcome you, Abhadi, to chair the session, and over to the chairpersons. And I request the chairperson to kindly introduce the speaker, Dr. Parikshit Tang.
Well, before I introduce the speaker,
Have the CV.
I wish to compliment Dr. Lakshmi for taking over this onus of fertility in ISOPAR. We are colleagues in ICOG as well, and she is a very close friend. And I'm sure she will be really taking ISOPAR to a higher level. Now, Dr. Parikshit, I know well since so many years, and I request my co-chairperson, Dr. Abharani, to please introduce Parikshit.
Thank you, Dr. Parul. First of all, I'd like to congratulate Dr. Lakshmi Srikhande for a launch on Fertility Enhancement Committee of ISOPAR. I know she'll do a great job, a great academician as she is. I would also like to pay my regards to the President ISOPAR, Dr. Gangadhar Sahu, the past President, Dr. Manju Gita Mishra, Dr. Usha Sharma, Dr. Arup Kumar Maji sir, and Dr. Pragya Mishra. And thank you, Supriya, for giving me this opportunity. And of course, Dr. Lakshmi Srikhande, thank you for making me a part of this beautiful launch of Seed to Bloom series of fertility enhancement in ISOPAR. And it's really a privilege to introduce a very academic and dynamic personality, Dr. Parikshit Tang. We have known him for years together, sitting on the FOXY dais. And he is the consultant Ashwini Maternity and Surgical Hospital and Center for Endoscopy and Assisted Reproduction, Mumbai, consultant Jupiter Hospital, Thane, honorary professor, Pacific Medical College, Udaipur, and consultant for assisted reproduction at 16 centers. He has been the treasurer of FOXY. He is the treasurer of FOXY, chairperson Safe Motherhood Committee FOXY in 24-17. He has been a postgraduate teacher and examiner, College of Physicians and Surgeons of Mumbai, examiner for MRCOG Part 3, managing committee member, Mumbai OBGY Society, has been recipient of many awards like Dr. K. Bhaskar Rao Gold Medal for first place at DNB, Dr. Kamini Rao UA FOXY Orator, over 100 peer-reviewed publications in index journals, CME publications in textbooks, co-authored 4 books in OB-GYN, and he's on the editorial board of 4 index journals. With such a great CV, I now invite Dr. Parikshit Tang to talk on a very important subject, that is male infertility. The stage is yours, Dr. Parikshit.
Thank you so much, Dr. Abharani Sinha. It's always a pleasure to be introduced by you and the chairperson, Dr. Parul Kotawala. Thank you very much for chairing this session for me today. I've just started sharing my screen, and as I'm doing so, let me convey my thanks for the kind invitation that Dr. Srikhande has extended to me, and in the same breath, congratulate her for this new responsibility that she has taken on behalf of ISOPARB. Fertility enhancement in the ISOPARB settings is something which will, enhance the total outlook of perinatology, and there's lots of work to be done in this regard. So my best wishes to Dr. Srikhande for this. It's wonderful to see so many senior practitioners and senior people who have literally carried ISOPARB from the days it has begun, right from Dr. Manjugita Mishra ma'am, Dr. Sahu is there, Dr. Maji, Dr. Sharma was here some time back, I think. So really wonderful gathering today of people who represent this very important aspect of perinatology. And of course, thanks to Dr. Supriya Jaiswal for keeping all of us together and running the program. So I'm going to speak about male infertility and carrying on from the theme of seed to bloom. I can just say that sometimes we have no seed, but we have to still make the flower bloom, in male infertility. So my talk today begins with a very, very fundamental question that what is male factor exactly? I mean, when we talk about male factor infertility, the most common thing what someone would think of, and I wouldn't blame them for saying so, is male factor means abnormal semen analysis, which could be either oligo or astheno or terato or a combination of those, which we simply call OATs. It could be a complete azoospermia, but male factor also includes male sexual dysfunction, which may be either functional or organic, and it also should include the lack of education, interest, coital frequency, so on and so forth. So actually, it's a very big spectrum of conditions that we are talking about in terms of the male partner contributing to the problem of fertility. Now, we are by far and large a collection of gynecologists in today's session. So the root question where we start with is, why should we bother? It's because half the couples who come to us with fertility problems will have a male factor, and it's important to understand what is exactly going on so that we can counsel them effectively. And we are the ones who have to do it because there is a big lack of well-qualified andrologists. I mean, if you're in a metro, it's all right. You'll find a reasonable access to andrologists. But if you're anywhere else, getting an andrologist itself is something which is difficult because inevitably you'll send them to a urologist or a general surgeon who will not really be looking at this man with the fertility point of view. So from that thought process, and from the fact that the patient is sometimes unwilling or unable to access andrology care, it's us who have to bother about the male factor. Our goals of evaluating the male are to assess what the fertility potential is, and if the man is deemed to be subfertile, then can we correct any identifiable causes, identify sexual problems and semen collection problems also. So, I mean, traditional teaching always starts with clinical medicine, but can the male factor really be identified clinically? The short answer to this is no, it can't be identified clinically. You may have some pointers. So, for example, a very obese man or a man who has a history of excessive tobacco consumption, alcohol consumption, a profession where there is a lot of heat exposure, or on examination, there is a scrotal swelling, surgery, trauma, any of the infections. Yes, okay. It points towards the fact that there might be a male factor, but what we need, and which is mandatory really in today's setting, is a semen analysis. Don't delay it and disproportionately investigate and treat the woman before turning your attention to the man. The story really begins with the semen analysis and the collection. 4 days abstinence. So anywhere between 3 to 7 days is okay, into a wide mouth container without condom or lubrication. And then we have to understand what exactly is fertile semen. Now, if you look at what's been happening from 1980, that's the time when the WHO started publishing the semen analysis manuals, you will see that the standards or the levels at which the cutoffs have been established have consistently been falling. So concentration 20 to 200 was supposed to be normal, then gradually dropped down to 15, 16. Look at what has happened to progressive motility. So gradual decline, and now progressive motility at 30. So every parameter, morphology, for example, drastic change. Of course, this is because of the new definitions that we use for normalcy. So, sometimes I ask myself, are men becoming lazier and aren't they even bothered to produce enough sperms, or have they finally become more efficient? But I think, apart from the headlines which talk about the decline in male infertility and the sliding rates at which men are fertile, what's important to understand is why this is happening. And one of the probable reasons is the environment. The environment really has multi-level effects. And in addition to the overall health compromises in terms of cardiorespiratory and immune function, it also affects the reproductive milieu from the internal disruptors, that is obesity and smoking, as well as the external disruptors. So environment produces hormone-like substances. It doesn't produce hormones. It produces hormone-like substances. So something which behaves like an estrogen will affect everybody, but it will affect the man much more. And that environmental hormone disruptors, along with the change in the internal environment which the man has, ultimately lead to a gradual decline in the semen parameters, which have brought us to this holistic understanding of where we stand with male infertility. There is aging, because older and older people want to become parents. That's true for the man, that's true for the woman also. And consequently, there's a change in the lifestyle which has happened, the highlight of which really is obesity. Obesity, along with probably not malnutrition, but bad nutrition, I would say. I mean, the people have enough to eat, but they're probably eating the wrong things now. Stress, anxiety, consumption of products like alcohol, tobacco, etc. And then, of course, pathophysiology and, as I mentioned, environment. All of these contribute, and that's how we get male infertility problems. Semen analysis is really the bedrock from where we start, and the ground rules that we have to establish for interpreting a semen analysis. If there's a normal report, accept it as normal. But if there's an abnormal report, that's not always abnormal. At least repeat it once before saying that, okay, this is probably looking like a male factor. The abnormal report could have come from the analysis being done at general laboratories. Now, semen is a biological fluid, and it has certain properties which have to be respected. In a general laboratory, typically semen being a non-urgent test, sometimes is literally kept on the back burner. It's analyzed late, it's analyzed in suboptimal conditions, it's not handled properly, and consequently you get reports which are not up to the mark. So what can you do about that? Use dedicated labs, and if you have a doubt, you could get a post-wash count done or a mock IUI preparation. What this does is it removes a lot of errors, and you come to a correct diagnosis much quicker than waiting for 6 weeks and 8 weeks and 3 months before repeating the semen analysis. Now, broadly speaking, I mean, if we were to look at the different abnormalities that we may find on a semen analysis report, the biggest chunk would be oats. I mean, it could be some combination of oligo, astheno, terato, or all of them put together. And this would literally comprise of maybe 90-95% of abnormalities. 2 to 4% would be azoospermias. And then you have the less common type of isolated sperm defects like globozoospermia, necrozoospermia, severe teratozoospermia, where you can hardly find, like, less than 1% will be normal. Isolated astenospermia, so on and so forth. These are isolated sperm defects. Now, when we consider these abnormalities and we are advising treatments, these are just the broad options that you can lay out in for the couple. Of course, azoospermia and isolated sperm defects are going to be treated by ICSI. You may have to retrieve the sperm surgically sometimes, and that's what I was alluding to when I said that when there is no seed, sometimes you have to still make the flower bloom. In terms of oats, you have a much wider range of abnormalities, and consequently, you have a much wider range of treatments that you can offer, right from medical therapy or intrauterine insemination or ICSI as a form of assisted reproduction. But before we go any further, I think at this stage, it's important to also take a very broad view, a very holistic view of where we are going in terms of the treatment pathways that we talk to couples about. And they should be offered treatment with donor sperm or adoption. And we have to make sure that we are conveying this information to them in the appropriate clinical settings that they have approached you with, and taking their background cultural expectations before we go down the pathway of various treatment options. I think it's equally important to remember what not to do routinely when you have oats. You don't always need hormone acids. FSH, LH, this is required only for azoospermia. Say you want to distinguish between obstructive and non-obstructive, or if you want to make a diagnosis of hypopituitarism, hypogonadism, yes, okay, hormone assays are indicated. Routinely doing scrotal ultrasound is really not productive. It's only if the man is symptomatic, has some scrotal symptoms, and you are looking for a varicocele before surgery, yes, you may do it. Antibody testing, DNA fragmentation index. This is the new kid on the block as far as male fertility evaluation is concerned. This is something, which I would advise a couple to do only if there is apparently normal semen, but recurrent implantation failures, recurrent pregnancy losses, recurrent fertilization failures. Yes, then I'll advise them a DNA fragmentation index. But when you have a grossly abnormal semen, it's quite natural that the DNA fragmentation index is going to be high. I mean, there's nothing that you're going to add value with when you are doing it in those kind of settings. So if it's borderline, if it's apparently normal, but you want to explain something, or you're looking for something in terms of a clinical picture which doesn't fit into that whole perspective, then yes, this is an extra test that you could advise. Doing a testicular biopsy today without preparation to freeze in is, I would term it virtually criminal, because you're doing a surgical procedure and you're not taking the full advantage of that surgical procedure. Of course, for oats, you're never going to do it. But even in an azoospermia, you're going to do it only with the backup available to freeze whatever tissue, whatever testicular tissue, whatever sperm that you're getting. You should be having the ability to freeze it. Do it in those settings only. So broad options for management of oats: masterly inactivity by the physician, of course, the couple has to be busy. Treatment of specific etiologies. If there is something that you found, say, if it is a hypogonadism, then yes, injections of gonadotropin are going to be useful. If the man has clinically significant varicocele, yes, varicocelectomy can help some of the men. Medical therapy is usually empiric, and then you go into the realm of the assisted reproductive options, including IUI, ART by ICSI, and third-party techniques. So when you're going to look at a man who brings you a report of oats, what do you have to ask yourself? You have to make your decisions based on the answers to these questions. What is the natural fertility potential of this couple? Now, see, this natural fertility potential is not some index. It's not like a Roma index or a biophysical score. There's no scoring really, but it's a clinical gut feeling, what you can gather from the entire history and the background that this couple presents to you with. I'll show you a couple of examples after this. The second question you ask yourself is, can the male fertility potential be improved? And if it can or can't, then you go on to the next one, which is that if I have to do something, what am I going to do? Will I do IUI or will I do ART? And can the man's sperms be used? If yes, then how do I best use them? Last but not the least, as I did mention earlier, we have to understand the psychosocial pressures, sexual dysfunction that this couple is facing, and what have they come for? What are their choices? And are they being directed by you in a rational manner? That's the decision-making tree for oats, really. So I spoke about fertility potential, and here I'll just illustrate with a couple of examples what I meant. You have two couples where both the men have come to you with this report. 10 million is the count and 30% is the mortality. But one couple is young, 25 years. They've been married for a short time, not received any treatment in the past. You're going to give them a long rope. You're going to give them an adequate trial of medical therapy. On the other hand, you have the same report, but it belongs to a 35-year-old couple who have been married for a long time, have already been around the block, and they've already taken medical treatment. Well, get on with assisted reproduction. Similar thing, young couple comes to you. One has a borderline count, 14 million, 30% motile, no past treatment. Give them some leeway, adequate trial of medical therapy. You'll be surprised to see how many people come back with a pregnancy just by themselves. But same, young couple, short trying time, but the deviation from normal is very large. 3 million, only 10% motile. Consider ART sooner rather than later. Now, when we are talking about medical therapy in oats, remember the tenets of empirical therapy, and all the treatments that we do in oats are empirical. The treatment should be safe, it should be affordable, and hopefully it should be efficient. There's no universal sperm tonic, and you have a bewildering choice of treatments that you can offer couples. The important thing is to understand that time is everything. The duration for which you're going to give this man treatment and look for improvement is important. You give them treatment for 2 or 3 months. That's really the bare minimum, because 72 days is the spermatogenesis cycle. And if you want to see some improvements, that's the least that you can do. If you see some improvements in the semen, well, then you can give them some more time, maybe another 6 months or so to get pregnant. Now, this is important because, keeping a time-bound kind of end to this kind of a trial of medical therapy is important. Couples will otherwise get lost to follow-up, or they'll get frustrated, or they'll start making irrational demands and decisions. So when you outline what is in store over the next few months, they have something to look forward to. They have some rational pathway to follow in terms of what you're going to offer and how you're going to approach the empirical therapy. Sperm tonic, well, here there is a bit of common sense advice which you really have to put forth. A healthy life, balanced diet and exercise, and reduce stress. Now, this is something which applies to virtually every man, every woman, every disease. I would go as far as to say that to every physician also. But I think this bit is really the most difficult part to follow. I mean, everyone will be okay with taking a couple of pills every day, but making root changes to lifestyle, now that's really a difficult ask. And here in the modern era, what we are facing is the pandemic of obesity. And obesity affects fertility in a multi-level kind of a approach. You are going to have excessive oxidation. You're going to have sexual dysfunction. You're going to have higher scrotal temperatures. All this put together is going to affect the semen analysis, sexual function, etc. Now, obviously, in these settings, macronutrition is important, but micronutrients and supplements have a role over here in this aspect too when there is obesity. And these are all your choices of empirical therapy that you can look at. Antioxidants, zinc, multivitamins, clomiphene, gonadotropins, oral testosterone, carnitine, coenzyme Q, so on and so forth. Ultimately, if nothing else is working, then we go back and turn the whole circle and go back to herbs. So you have herbal, and then beyond that, there's only verbal. So you just tell the man that, okay, you keep trying and let's see what happens. Now, the modern concept of supplements or micronutrient therapy is really to use multiple agents given as a package, because you've got to look at spermatogenesis and maturation and the mechanisms which lead to healthy sperm working at different levels. So the target is to reduce the oxidative stress, and it is to improve the cellular function by mitochondrial mechanisms. So that's why you need micronutrient therapy, which is a multi-agent therapy. There's no one single agent which is going to help in this regard. Where is the evidence on this? Well, what does Cochrane say? It has a fairly large review of 61 studies over 6,000 men. And it says that it improves micronutrient therapy, antioxidant therapy, improves live birth rates and clinical pregnancy rates. The evidence quality is low, but what I want to draw particular attention to is what I have highlighted in yellow on the slide, that this is therapy which is given in fertility care and for men and couples who are undergoing assisted reproduction. So if you've got a man who's for a long time had very severe oligozoospermia, 2 million, 3 million, 4 million, that's not what is going to get treated with antioxidant or micronutrient therapy. What you're changing is the quality of the sperm, the DNA content of the sperm, and consequently, when you do assisted reproduction with this sperm, you're going to get better live birth and pregnancy rates, consequently, a good perinatal outcome. So a trial of empirical therapy should just be that, a trial. It's not a challenge to the testes, to the man or the doctor who's prescribing. Now, let's move on to beyond medical therapy. And the next simplest option that we can offer men with oats is an IUI, intrauterine insemination. Here, I always say that everything that can be done should not be done, because there's virtually no couple for whom you can't do an IUI. The minimum requirements are almost always met. The question that we have to ask ourselves is, will this couple really benefit from doing the IUI? So in an IUI cycle, you would typically expect live birth rates of somewhere around 12 to 15%. Are you going to hit this mark if you're going to use this man's semen and inseminate the woman with that? And to do that, to realistically achieve that 12 to 15%, These are the parameters that the semen should have. A raw count of more than 10 million, 20% motile and at least 5% normal, and a post-wash count of at least 5 million with more than 90% motile sperms, then you're looking at reasonably good results with IUI for the man who has both. IUI success rates are semen dependent. And if you look at this chart, you'll obviously see that IUI, you're going to get the best results if the counts are higher. It's obvious. Now, higher sperm counts will result in higher success. But IUI has the maximum impact when the sperm counts are only mildly impaired. So if you have a man who has a normal semen, then there's no point doing IUI because he'll be able to impregnate his wife anyways. If the man has very bad parameters, IUI is useless. So it's only good for that borderline kind of semen that you can offer IUI and make some significant difference. Of course, when you're doing IUI, if you combine it with ovarian stimulation, that boosts your results quite significantly. What about azoospermia? Surgical sperm retrieval results are great. And what we have found is, and this has been validated over a number of different settings, is that it doesn't matter what's the source of sperm, whether it's surgically retrieved from the testes, the epididymis, or it's from the ejaculate. ICSI is going to give you the same results in terms of the live birth rates. Now, there has been a trend of doing surgical sperm retrieval in very, very bad oligoasthenoteratozoospermia. Does that change results? That's the modern question. And the answer is probably no. If you've got sperm which is ejaculated and you're able to isolate sperm from the ejaculate in whatever number and in whatever form, you're going to pretty much get the same from the testes. So you'll not drastically change anything by doing a surgical sperm retrieval in oats. So testicular biopsy today is basically a needle biopsy. We no longer really open up the testes unless one is doing for non-obstructive azoospermia. And this completely makes the procedure almost to the point of non-invasive. It's very convenient and very easy to do TISAs in this manner. So should we treat the man? Should we treat the gamete? Or should we just look at a replacement? These are the philosophical questions going forward when we look at male infertility. So thank you very much for your kind attention.
Thank you very much, sir. Now over to Abhadi to sum up.
Thank you, Dr. Parikshit. Indeed, it was a wonderful talk, very brilliant talk. You have touched all the issues right from basics, like proper semen analysis, right to what not to do. I think that was the best part of your talk, because when we see prescriptions, there are battery of tests written for no reasons, like LH, FSH, DNA fragmentation index, everything. And testicular biopsy, I think they have to be done in selected cases. And you very rightly pointed out that we should freeze if we at all we are doing an invasive procedure. I think that was a very good point that you brought out. Then use of medical management. I think everybody is writing right and left for years and years together, these antioxidants and all. But you have very rightly pointed out how long to give. I think the duration is the most important. We know the cycle of spermatogen, maximum 2 to 3 months, and if improvement, further extended to 6 months. I think you have brought these points very well. And right about sperm retrieval, when to, if we get even from the ejaculate and we inseminate, we get a better results. So we should not go just for TISA in all the cases. I think all those points have brought in very well. A very lucid lecture. I think I'm not very fond of learning male infertility, but today I think you have enlightened us so well about this whole topic. And always your last slide is wonderful. And I think from Vicky Donor, what you have brought that slide, I think I really appreciate that. Thank you so much, Dr. Parikshit. And over to Dr. Parul for his equally, I think, very, very intelligent and very informative comments. Dr. Parul, please.
No information from me. I just compliment Parikshit for a complete coverage of the entire topic. male infertility is on the rise, and that is going to be more and more a challenge for all of us to handle. And I believe that all OBGYN practitioners will have to focus quite a bit on male fertility aspects as well. Till date, we used to pass on these cases after a little bit of management to the urologist for if the patient is insistent on their own genetic pool, because the easy way out was to just collect donor semen and get on with it. But definitely, most parents would insist on their own genetic pool. And so we will have to focus more and more. Thank you, Parikshit, for a very lucid presentation.
Parikshit, I'm so happy when you asked me ki what I want, and see both the chairpersons are saying the same thing. Now they have started developing interest in managing male infertility. That is what I had told Parikshit. Parikshit, ekdam basic batana, and you really did full justice, Parikshit, full justice. I mean, it was really very lucid, very informative talk. From basics to advanced, you covered everything.
Dr.
Thank you.
Parikshit, I want to, I don't know whether I missed
Hi,
because I
Dr.
got,
Pragya.
yeah, because I got a few phone calls, you know. I rarely do a testicular biopsy these days because it go for FSH, and you know, then I usually, depending on the values, whether it's above 10 or it's below 10. I mean, that's how I rarely do, but still, you know, people are doing testicular biopsy. So I was wondering whether, you know, whether I'm wrong or they are wrong.
No, you're absolutely on the right path. And I expressly mentioned that it's probably one of the things that you should not do in oats. So I think the FSH level is a good discriminator, whether you're looking at obstructive or non-obstructive. Of course, there's nothing 100%, but it gives you a fair idea about where you're going in terms of your chances with even surgical sperm retrieval, for example.
And what's the, like when you do a testicular sperm extraction or a testicular sperm aspiration? So, I mean, I just want to know in what way, like in my center, we are doing extraction. So in what way, I mean, is extraction superior to aspiration?
So aspiration is usually done with a thinner gauge needle, and it doesn't give you any testicular tissue. Whereas an extraction, a TESE, is the one which is done with a little broader gauge needle, and it will give you some tubules and some testicular tissue. So, yeah, we normally do a TESE.
Thank you.
Well, thank you very much. We come to the end of this session, and I really thank the brilliant speaker, Dr. Parikshit, thanks sir, and the chairpersons, Dr. Parul Khatrawala sir and Dr. Abharani Sinha. So we come to the end of the session, and the webinar is over. And just to sum up, vote of thanks. I'm really privileged to extend the vote of thanks on such a wonderful day, the launch session of Seed to Bloom web series of Fertility Enhancement Committee of ISOPARB by none other than the Dr. Lakshmi Srikhande madam. In spite of being the ICOG chair and so busy with her work, she's very hardworking, meticulous, multitasking. She's very, all the time she's multitasking actually. Really, thank you very much for having me also with you as co-convener. Thank you, madam. Special thanks to President ISOPARB, Dr. Gangadhar Sahu sir, who's logged in with and had been the chief guest, along with Dr. Manju Geeta Mishra, who's the center, the backbone of ISOPARB. It stands on her only. Both of them gave the words of blessings to this new committee. And then we are fortunate also to have as guest of honor, Dr. Arup Kumar Majhi sir, who is the incoming President ISOPARB, Dr. Pragya Mishra Chaudhary, Secretary General ISOPARB. They also have enlightened on this subject and gave their best wishes to the committee, new committee. Dr. Usha Sharma as special guest, who was the immediate past president of ISOPARB and had a wonderful tenure. Then the brilliant speakers, Dr. Gaurav Mishra from UK and Dr. Parikshit Tang sir from Foxy, India. So both the talks were very lucid, very informative, and I think the audience must have really benefited from this. The very respected chairpersons, Dr. Hiralal Konar sir, Dr. Archana Kumari, Dr. Parul Kotawala sir, and Dr. Abharani Sinha. All four of them, in spite of this being odd time for everyone to join, still everybody was on time and interacted so well with the discussions. So I thank really all the viewers and the technical support, Chitrakala and Shahiti. I also thank everyone. I hope I didn't miss anyone, but the interactions, Pragyadi, thank you very much for interacting with all the speakers and the chairpersons. It was a wonderful webinar. And I really thank everyone and the other people, Dr. Rita Jha, Nibha Mohan, Amita Sinha, Ranjana, Dr. Ranjana, all of them have logged in. And thank you very much for this wonderful webinar. Thank you, Dr. Lakshmi Madam. Thank you.
Yeah, Supriya has thanked
Thank you, Dr.
everyone, but
Lakshmi.
I would like to extend my thanks to Supriya because this would not have been possible without Dr. Supriya's efforts. So thank you so much, Supriya.
Thank you, Supriya, Dr.
Thank you
Lakshmi.
all.
And we will all meet at Mirat.
Yes,
Yes.
Meerut we are meeting. Yes, sir.
Hope we'll all
Virat
meet.
in a big way.
Mirat.
Yes.
Sir,
No,
we
no,
are
but
meeting
not
you on
coming to
2nd of
Patna.
April, sir.
Yeah,
Not
yeah.
coming to Patna.
We will meet you on 2nd of April.
Second,
Not
nahi,
second.
8th April.
Oh,
Eighth
Pragya
April.
now it has-
Second, Dr.